So my name is Andrew Nooner. I'm the CEO for the Health Quality Council of Alberta, and thanks very much to the BC Quality Council for the invitation to come back to BC to be part of this. And just to let you know, it's 1 degree warmer in Calgary than Vancouver. So I made the right choice. I'd like to introduce our debaters today. We have Marie Leijen, who's the Executive Director of Valley Care Residential Home and a practicing nurse. Stephen Lewis, who is a health policy and research consultant and our Quality Forum moderator. Andrea Wong, who's a fifth-year undergraduate pharmacology student at the University of British Columbia. Andrew Purrsell, second-year medical student at the University of British Columbia. Helen Bevan, Chief Transformational Officer at part of the Horizons team at NHS Improving Quality. And Devin Harris, who is an emergency physician at Kelowna General Hospital and the Stroke TIA clinical lead at the BC Patient Safety and Quality Council. So I'd like to start by introducing the motion. Clinical autonomy is the enemy of improvement. And before we engage with our debaters today, who have been succinctly debriefed on the amount of time they have and understand all the penalties for exceeding their time limits, I'd like to ask you, the audience, to show by means of applause whether you are for or against the motion. So can I hear applause if you are for the motion? And those who are against the motion. All right, I think for the time being, the against group has it, but we'll see at the end of the debate whether you have switched your loyalties as we work through our debate. And so our first speaker is Andrea Wong, who will be debating for the motion. Andrea?
So good afternoon, everybody. I've been given the task of convincing you today that clinical autonomy is the enemy of improvement. Now, all of you who just clapped for against the motion probably think this is ridiculous because as a health professional, you should have the right to make independent decisions on your own of how you should treat your own patients. What we're going to tell you on the proposition side is that independent decision-making by individuals within our healthcare system is actually inherently harmful for providing the best care for our patients. So let's step back for a moment and consider the role of a physician. Our goal in healthcare is to provide the best treatment for a patient. The problem here is that what the best treatment is varies from professional to professional. We all have different experiences, we all have different specializations, and we have different ways of looking at the same complex cases. So what we see is that different professionals will come to different conclusions and have varying ideas on what the best, most effective treatment is. We think that this is inherently harmful when we have healthcare, when we want to provide the basic standard of healthcare for everybody. We don't tolerate variation within professionals, especially when we could have the risk of running lower quality healthcare due to some professionals who may be less experienced in certain situations. We think that everybody needs to have a certain basic equal standard and consistency when they receive healthcare from professionals. What we need in the system is that for professionals to have certain guidelines on how to act if they don't have the certain experience to deal with certain situations. What we need is for physicians and health professionals to work together as a collective to come to collective decisions. Because physicians are not single independent actors when it comes to providing healthcare. Physicians are members of a representative of the entire healthcare system. We all work together to provide different types of healthcare to the same patient. A single patient over their entire lifetime will come into contact with family doctors, with specialists, with nurses, with pharmacists. All of us together work together for the same goal. And it doesn't make sense for us to all have different conclusions when working with the same patient. The problem is that we all are components of the same machine, but when these components have different perspectives, we often come into conflict on decisions on what is the best, most effective treatment. So what we need is communication and an obligation for physicians to work cohesively and collectively so they hold each other accountable for providing the best care. We often misconstrue treatment as something that is a result of a patient-physician relationship, a one-on-one relationship. That's not the case. What we have here is a relationship with the patient and the entire healthcare system. And so what we have in the concept of clinical autonomy, where a single individual can make their decisions independently from anybody else in the system, is inherently not compatible with what we really have in practice, which is all of us together working to come up with a collective decision. We have so many different health professionals here. We all have different specializations. We all have very different perspectives. And I guarantee you, if I give you a case today, you will all have different decisions on how to treat that patient. We want all of us to work together to come up with the the most effective decision based on all of our knowledge. We are arguing for communication between all these different specializations to provide the best effort. So when we say that clinical autonomy is the enemy of improvement, we're not denying your ability to make sound decisions. We are reinforcing that you must make them collectively all together in order to provide the best, most effective treatment for your patients. Thank you.
Thank you, Andrea. Strong opening arguments, bonus points for being exactly on time. And I think I heard a little bit about physician autonomy in there, so who better than to argue Andrea's points than Andrew Purrsell?
Right. So I want to thank Andrea for her definition of clinical autonomy, but I think that she's left out a couple very important points when you have this definition. And really what this is that practitioners of healthcare have sole discretion in the delivery of healthcare, but this is based on clinical context and patient preference. And so this is bringing these ideas together to have a good solution. And she mentioned that they're not accountable. Well, they are accountable. They're accountable to the college, right? A self-appointed regulatory body that ensures clinicians provide reasonable care. When we're talking about this statement with that in mind, I think you can more correctly interpret it as allowing clinicians to have sole discretion in the application of healthcare prevents us from obtaining the best healthcare. I think today, though, we're going to demonstrate to you that clinical autonomy allows for excellent delivery of healthcare. It can help us navigate challenging ethical situations, and through its inherent nature of innovation, is instrumental to the improvement of healthcare. But before we talk about the improvement side of it, I first want to convince you that clinical autonomy is rightfully so one of the core tenets of how we deliver healthcare in Canada. And I think this is best done by examining the crux of clinical autonomy itself, and that's clinical judgment. So I was wondering, well, how good actually are doctors at making the right diagnosis? And I'm not the only one that wondered this. In 2013, there was a study where a group of investigators compared Gestalt, which is that gut feeling that a clinician has when it sees some sort of clinical presentation, with literature-validated clinical criteria. So these pre-designed systems aimed at figuring out the right diagnosis. So the first thing that they found was that an attending was 81% accurate in calling pulmonary embolisms a potentially fatal clinical complication. And while they've argued that experience might affect this, it actually turns out that a first-year resident, so someone that has just gotten their MD, is 71% accurate. Most of this experience is captured in medical school and allows them to make good diagnoses. What they found compared to these clinical decision rules, though, was that clinicians were better. They were actually considerably better at it. And these clinical decision rules had a bad habit of ruling out pulmonary embolism, a potentially life-threatening illness, when they shouldn't have. So what that says to me is that protocols are unable to account for the complexity of clinical presentation, and clinicians can better understand those subtleties. Of course, this begs the question, what if we add more information in? Maybe these protocols just aren't enough. And that was the realization that they had around year 2000. And what the idea was, they designed these clinical decision support systems. And this is where a computer algorithm looks at electronic medical records, takes in the symptoms and signs, the vitals, all the presenting things, and spits out a likely diagnosis and management tips to the clinician. And what better way to temper clinical intuition than with raw computing power that can appreciate probabilities and likely presentations? Well, a meta-review was done actually in December of 2014, so it was completed just a couple months ago. And what they found is despite massive costs of implementing these systems, there was no difference in mortality. It is very hard to build on clinical autonomy as an effective way of delivering healthcare. Now, while this had increased costs, other attempts to curb clinical healthcare in the aim of improving its outcome have also met less benign outcomes, and one of which is litigation being used to hold physicians accountable. We've seen what happened in the United States. We don't get better medicine, we get a lot more tests, where physicians do tests aimed to protect themselves against potential lawsuits. This drives up resource costs and doesn't result in any better outcomes for the patient. In Canada, in the last 20 years, there had been policies on intentional resource limitation. And the idea was that if you made resources harder to come by, then they'd be used less. But what actually ended up happening is that this created lines for everything. The system became inefficient, and humans suffered as a result of having to wait for the treatments that they required. So once again, by trying to change clinical autonomy, you've increased costs and harmed the patients. So altogether, clinical autonomy is not the enemy improvement. In fact, it's a central cog in our health system. And I believe, and I think as my colleagues here will show you, it will facilitate the delivery of effective care now and into the future.
Thank you, Andrew, for that strong technical argument. No bonus points, even though you finished on time. However, a bonus points for the clever strategy of having the same first name as the moderator. So now that the grounds for the debate have been clearly established, we turn to Stephen Lewis.
Oh, thank you. I'm going to take the unusual step of using my first 30 seconds to apologize to our opponents. Our side of the argument is so self-evidently true and persuasive that it may be psychologically damaging to put these people through the sophistry that they're obliged to hand out to you in defense of a system that they would not send their family members to should it continue to exist. And indeed, the very fact that we're here under the auspices of the BC Patient Safety and Quality Council is the reason why the council exists, and the council exists to undo the consequences of 100 years of clinical autonomy in Canada. Let me elaborate briefly. Autonomy literally means to act without external constraint. Acting without external constraint means you can do what you want to do, irrespective of the consequences and accountable to no one. That is not a recipe for excellence in any walk of life, and I will elaborate on that anon. But it is particularly not a way to proceed in an area as complex as healthcare, where there is so much clinical knowledge combined with so much uncertainty and so much human drama and tragedy. Now let's just, for the moment, put the best possible face on this and say, how could this work? What would need to be in place for this to work? Well, first, it would have to mean that independent judgment is the best guarantee of quality. People acting independently, making judgments independently, is the best guarantee of quality and improvement. It also would mean that professionals uniformly know what the best evidence and the best practice says and is, and uniformly apply it. It would also mean that where there is deviation, that it is invariably positive deviation, or if it is not positive deviation, it's an experiment which the autonomous professional would submit to evaluation in order to learn from it and to minimize harm. Well, that's a pretty tall order to expect. Unfortunately for our opponents, this isn't just a theoretical case. The evidence, the mountains of it, are before us. In my own city, if you have breast cancer and your first surgical intervention takes place at Royal University Hospital, you will have a 70% chance of having a lumpectomy. If you go across town to St. Paul's Hospital, you will have a 25% chance of having a lumpectomy. If, and this would apply to probably a maximum of half of you in the room, you happen to have a severe prostate symptomatology, and you're in Regina, you are 4 times as likely to have a radical prostatectomy as you are in Saskatoon. This is because clinical autonomy reigns and people are making autonomous judgments about what's best. They're all well-meaning people. There is no evil here. The sin is not intention to do bad. The sin is hubris and lack of collective accountability. So the syllogism is pretty clear. Autonomy invariably breeds variation. Otherwise, why would you want it? There's no point in having independent judgment if everyone is the same. So autonomy virtually demands variation, and in healthcare, unwarranted variation causes harm. There is underservice, there is overservice, there is misuse of services. Now let's take another analogy. Supposing we extended clinical autonomy to other professions. If it's a good idea in medicine, this big, massive, evidence-fraught beast with a lot of uncertainty, well, why don't we apply it to engineering? So those of you who drove across the Lions Gate or the Second Narrows Bridge to get here, would you have driven across that bridge if engineers decided on the structural characteristics of a safe bridge and had a 4-fold variation in their opinion? I don't think so. Or supposing you had a football team, and instead of having an orchestrated, common sense of purpose where everybody practiced according to the plays and the pathways, you said to the receivers, run out there and I'll throw it to one of you. I don't think that team would make the Grey Cup. But the origins of all this can be traced historically. Recent biblical research has unearthed the root cause of this. When the Israelites were being led out of Egypt by Moses, you may recall that the journey took 40 years to go about 250 miles, which is very analogous to the healthcare journey to quality improvement in Canada. And one of the reasons for this is because they were waylaid by the worship of the golden calf. And the golden calf, the false idol, has been revealed by recent archaeological research, is called clinical autonomy. So they had to melt that sucker down. And they had to replace it with, in the service of parsimony, 6 commandments. And I'll now read those 6 commandments to you. The first is, thou shalt be humble and strive to know what thou dost not know. The second commandment is, thou shalt fear unwarranted variation in practice and sit with thy peers to address it. For if thou do not do this, your patience they shall suffer. The third, thou shalt be patient-centered and creative, but explain thy reasons and evaluate what thou hast wrought when you depart from an evidence-based care pathway. The fourth, heed not those who say, it shall be done thus, for it has always been done thus, and I am the king of thy castle in this thy community. Trust in God, all others bring data. Fear not care pathways and standardized protocols, for it is thus in the kitchen. good cookbooks hath created more excellent meals than 1,000 cooks making shit up. And finally, be not alone in thy practice, but lean on thy colleagues as they shall lean on you. For collaborative interdependence is the way of the Lord, or at least a good strategy for not killing thy patients. Thank you.
Thank you. Thank you, Stephen. Tough not to award extra points for fear of divine retribution on that, but I was surprised that you unveiled the BC Lions offensive strategy in your comments. Knowing that Stephen's comments would be thought-provoking, we went east from Vancouver to the other end of Canada and found ourselves needing to go across the Atlantic to find a suitable debater for Stephen.
Good.
So I introduce
I
you,
accept the
Helen.
challenge. Okay, so I would like to build on Andrew's arguments and talk about not only why clinical autonomy is not the enemy of improvement, but that clinical autonomy is critical for improvement. So audience, note that word, okay? Improvement. Because Stephen, good job. You milked this audience, okay, for cheap laughs. But, okay, but I would like you to remember that what this conference is about. This is an improvement conference. You talked about quality, you talked about why clinical autonomy was wrong, but you didn't give us any alternative. You didn't talk about improvement, and I think that is your fatal flaw, mister. So, why is clinical autonomy important to me? When I was 20 years old, I was a student, and I had significant mental health issues. I had anxiety that was so profound that there was a great likelihood that I was going to drop out of college. I was treated by my GP, who was great, and he thought that I would benefit from being taken under the wing of the trainee GP that was allocated to his practice. And they broke all the rules and just looked after me in the most amazing way. And this trainee GP, Jo Fleming, she took me to her house. And I can vividly remember, as a 20-year-old, sitting there in the sofa of her front room, her lounge, nervously chewing the nail varnish off my fingernails. And you know, what they did was completely against the rules. It was really unorthodox, but it was right for me. And like when I look back over my whole life, that was actually one of the turning points for me. And I would not be where I am now if they had not done that for me, autonomously. So I think there's a fundamental issue here, you see. When we think about autonomy, I think it's a basic human drive, you know, the urge to work in a way where we can control what we do, where we do it, who we do it with. I think it is an absolute human requirement. And I get, in my job, I'm very lucky, I get to work with healthcare systems all over the world. And you know, outstanding healthcare leaders really understand this need for autonomy. And you know, what really stands them apart is how they trust their clinicians and they give them space. And why do they do this? Because actually, in general, clinicians are really smart people. They're very talented, you know, they're self-directive and they're creative. And when, as Stephen suggests, we smother our clinicians with micromanagement and command and control and the kind of oppressive guidance that he suggests, okay? These leaders treat their clinicians as if they are dumb, lazy, and unmanageable, like you insinuate. And guess what? It becomes a self-fulfilling prophecy. So I have listened with interest to the first two speakers, and I respect the arguments that they make. But I think that they're missing one really critical ingredient, okay? A critical ingredient for change and transformation and improvement, okay? The world that we live in. And that word is passion. You see, autonomy is absolutely critical for passion and creativity, the things that we need if we are going to transform our healthcare systems. And if we look all over the world, we see the same thing. Autonomy leads to passion and it leads to creativity. So if we are going to transform our healthcare systems, the very mission that brings us all here today, all 750 of us, then if we are going to give our patients the high quality care, the great experience that they require, then we need our colleagues, our teams to have autonomy, the space to do the right thing. So our opponents here say that we need standardization, we need to reduce variation, we need to ensure good practice. Actually, I'd say you're thinking the wrong way round. You see, what we really need to be doing is we need to be building energy, passion, commitment to change. Because what I see in really great healthcare systems is that when we build that commitment to a common purpose, compliance just happens. We don't have to force it down onto our clinical colleagues. You know, history shows us actually, Stephen, that you cannot drive compliance through compliance. It doesn't work. And I see the effects of many, many healthcare systems across the globe seeking to do that. And I see those downtrodden clinicians, and I see that lack of passion, and I think it is a tragedy. So, ladies and gentlemen, you have the opportunity to vote in this debate. Please vote for autonomy, passion, creativity as the fuel for healthcare improvement. Vote for a future where diversity, dissent, disruption is regarded as highly as the kind of cohesive, conformance-based, coherent, negative world that Stephen shows us. Okay? We are a social movement of passionate, creative people, okay? We can change the world. Bring it on. Vote against the motion.
Thank you, Helen. Well argued, and certainly extra points for the passion you brought to the debate, and another half a point extra for taking on Stephen in such a good way. So now for the affirmative side, we turn it over to Anne-Marie, who will bring home the argument for the motion.
I agree, we need a social movement, but we need a social movement that tells you that when you end up in hospital, you are going to be guaranteed to be leaving healthier than when you arrived. And that when your mother ends up maybe in a nursing home, that she's going to be in the best one. Not the one, I believe this was the comment, let me remember. You know, your doctor's gut feeling, it's just going to tell him and her the right thing to do. 71% of the time, I think is what you said. Is that right? Well, you can roll the dice and get 50%. So I'm thinking, you know, 10 years of medical education, we're hoping just a little bit more than a 20% improvement. I think that our clinical autonomy, it causes unwarranted variation. And that was Stephen's point. And I think you really, really need to think about this, because this comes down to treatment of people that are similar with similar problems. And this can be, in my workplace, really shown in the prescribing of antipsychotics. So you can have one facility that has 10% subscribing rate and another one that has 80%. Well, where would you want your mother to live? I don't think that variation would make you feel good, if in fact you actually even knew and someone took the time to tell you what their statistics were. So that's the first point, unwarranted variation. I think that by the very definition, clinical autonomy encourages us to believe that connecting and engaging with others limits us. So clinical autonomy is the enemy of improvement because it says to you, you don't need to talk to me. And it's these very things, teamwork, connections, working together, developing that shared purpose, like Helen says, that shared purpose and that energy. That comes by working together, not to be this autonomous person out there making decisions for other people and expecting everybody to follow down the road. The surgical safety checklist is another example of communication that has prompted comprehensive conversations that prevents adverse events. And it's stopping that clinical autonomy in the operating rooms. so that everybody works together and you know each other's first names, and it makes a difference. I think that the third aspect that I would like to bring forward to you is that clinical autonomy, it ignores the system that it works in. Improvement of care is a process, and it happens over time, and it happens over space. And I think several clinicians are going to guide the action taken in more than 40% of the people that we look after that are elderly with complex care needs. And so it makes it harder to define who made the decision, who has the responsibility. So we require collective work, not clinically autonomous work for improvement. Clinical autonomy ultimately results in fragmented care. And I would urge you to consider an alternate view from the one that Helen put forward, that clinical autonomy means that you're doing the best thing for one person, because we all look after more than one person. We need to look after thousands of people. They come through our facilities, our organizations, and we owe a debt of care, time, and attention, and leaving our hospital with better outcomes than when they arrived. In my opinion, there is absolutely no doubt that clinical autonomy is the enemy of improvement. As Stephen said, the rest of the world gets this. Airlines, engineers, they understand that those standard processes that we put in place that we want everybody to follow are there for the vast majority of time. We have experts, masters in their field working throughout the healthcare system to notice those outliers, those people that don't follow that clinical path. That's why we hire the best of the best to work in our hospitals. What we really need is teamwork, coordination, collaboration, and we need to do it together, and clinical autonomy ignores those requirements. Helen says that clinical autonomy is necessary for passion and creativity. I agree. Everybody needs to have their thoughts, their needs, their energy brought forward for the greater good, but not in an autonomous way. You need to do it with your colleagues, your friends, your patients, and their families, and that is how we're going to improve our healthcare system, and that is how you're going to know when you walk into that hospital, you're going to walk out and you're going to end up going home better than when you arrived. Thank you.
Thank you, Anne-Marie. Also well argued, and points for leaving no doubt what side you're on. Turning over to Devin Harris to bring home the argument for the against side.
Thank you. Honorable moderator, ladies and gentlemen of the audience, esteemed co-debaters, intelligent, witty, well-dressed, good-looking, and the others on the other side of the podium. I would like to speak to you and your common sense. You, as rational people, have been invited to be adjudicators for this debate, and I want to speak to you about you and how a reasonable person would come to the conclusion that the statement, clinical autonomy is the enemy of improvement, is false, incorrect, bollocks, balderdash, pish-posh. I'm just saying that for Helen because I'm speaking in English colloquialisms. But it's not relevant, and these are the reasons why. And you might first ask, who am I to have the moral authority or authority to stand up here and speak to you people as well? So I am a physician, I am a researcher, I am an administrator, I am also an educator, but that's irrelevant. I am a patient. My wife is a patient. My kids have been patients. My grandparents and parents have been patients as well. And so on that account, I will speak to you all as if any of you came up here, you would speak in the same way that I will as a patient. Based on all the evidence presented here today in front of you for 40 minutes, I will show you and summarize the fact that this clinical autonomy as the enemy of improvement is false. And these are the reasons why. I'd first like to state that Mr. Purrsell, our first lead-off, presented his cases clearly and accurately outlined the facts and had up-to-date references, not like Mr. Lewis, who took 2,000-year-old references to bring us up to date. Second is, I think, Ms. Bevan, in her years of experience and specialized knowledge and acquired from those years of knowledge, is able to comment and provide a trustworthy account of the facts that were presented thus far. To the points. From the initial presentations of the pro side, the statements are variability is based on individual specialties, and autonomy breeds variation. And the comment further to that is that variation is undeniably negative. And that's the tenet behind the whole pro-for side of the debate, is that variation is negative. And that is absolutely incorrect. Take, for example, the person who decided to x-ray their hand and discover over and over again that, yes, you can use x-rays for advancement of medical care. How about the guy who put his sandwich up on the side of the lab, accidentally discovered penicillin? And for example, an Australian gentleman who ingested bacteria himself to cause stomach ulcers and then treat those to then get rid of stomach ulcers and won the Nobel Prize for that. Is that not variation? Is that not radical thinking? Is that not taking a step outside guideline-based care and directive-based care? I definitely think so. As an aside, I would like to submit to you, reasonable people of the audience and adjudicators of this debate, that a paper that I looked into, written by a certain S. Lewis, from the Journal of Health Services Research and Policy in 2007, states, and I will say clearly, that he defined medicine along a continuum, quote, from algorithm to art. And I quote, "Where knowledge is definitive, rely on the algorithm. Where knowledge is provisional and incomplete, redouble scientific effort. Where uncertainty looms large, engage the right side of the brain." Unquote. And I think this speaks to such renowned authors as Malcolm Gladwell in Blink, Daniel Kahneman, a Nobel Prize psychologist in his book, Thinking Fast and Slow, and Charlie Brown. Further to that, I would like to go back to what Helen has said, because my name is Devin, her name is Helen, and his name is Andrew, that when she spoke about the fact that she had anxiety such so that she considered dropping out of college, here she stands in front of 600 people being able to speak and change how we think about things. Andrew related a story to me about the fact when his grandfather was in the intensive care unit, and on a pathway where they were considering withdrawing care, a radical, a revolutionary intensivist physician decided that they were going to continue ongoing care. He survived, was discharged, and lived for a few years later. My own personal anecdote is my mom had melanoma, and 5 years after the diagnosis of melanoma, she developed metastatic disease and became confused. She was admitted to hospital and was considered palliative. A rogue physician decided that the best thing for us and asked would be, would you like to give a medication to allow her to wake up to see you, have conversations, visit with her grandchildren? We did. She lengthened her length of stay, stayed in hospital longer, went against all aspects of palliative direction and care, but we were able to have final words with her as well. In closing, and I realize I won't lose bonus points because I'm over, I would like to say that the statement is false. But I do think that openness, communication, teamwork, and open debate like this amongst all of us in the healthcare professions will be the solution to improvement. And to that end, the con side rests.
Thank you, Devin, for your compelling statements. And although I had deducted points for time, including all your panelists on your side and their respective families in the debate, got you some extra points back. So, audience, it's time when we come back to you. You've heard both sides of the argument, and you've heard a lot of testimonies, both personal and professional, and it's up to you now to decide where you fall on the question of, is clinical autonomy the enemy of improvement? Through a show of applause, can I hear those who believe Those who are against the motion, clinical autonomy is the enemy of improvement. Thank you. That was a very civil Canadian response. And now, for those who are for the motion that clinical autonomy is the enemy of improvement, can I hear from you? All right. By a whistle, I believe that the for side has won the debate.